All right, let's jump right into proximal femoral fractures. These are, without a doubt, one of the most common and critical injuries you're going to see in orthopedics. Getting the management right from the very beginning is absolutely crucial. So today, we're going to break down everything you need to know, from classification all the way to the nuts and bolts of surgical treatment.
You know, these fractures are a huge clinical problem, especially in our aging population, where a simple fall can literally be a life-altering event. A fast, accurate diagnosis and a solid treatment plan are non-negotiable. And understanding this stuff, it isn't just for your exams, it's fundamental to your day-to-day clinical practice.
So, here's our game plan. We'll kick things off with the clinical context. Then we'll get systematic with fracture classification. After that, we're diving deep into the different ways we manage femoral neck versus trochanteric fractures, and then we'll wrap it all up with the key takeaways you've got to remember. Okay, so let's set the stage. We'll start with the clinical context to really understand why these fractures pose such a significant challenge in the world of orthopedics. Just think about how often you'll see this. A full 50%, half, of all proximal femur fractures happen at the femoral neck. I mean, with a number like that, it's a guarantee you'll be seeing, diagnosing, and managing these specific injuries constantly. So with so many of these injuries coming through the door, we need a system, right? And that brings us to classification. Look, in orthopedics, how you classify a fracture directly tells you how you're going to treat it. It's that critical first step that takes you from diagnosis to a successful surgical plan. We can break down the proximal femur into 4 key anatomical zones, and each one comes with its own unique set of problems. Fractures of the femoral head itself are pretty rare. What we mostly see are femoral neck fractures, then trochanteric fractures, that includes both and intertrochanteric, and finally the subtrochanteric region, just a bit lower. The biology and biomechanics of each spot are wildly different, and that's what drives our treatment decisions. Okay, here is the absolute crucial point to remember. Femoral neck fractures are intracapsular. They happen inside the joint capsule. That single detail is the key to unlocking their entire pathology. Why does it matter so much? Well, the blood supply to the femoral head is, let's just say it's tenuous, and it runs right along the neck. A fracture here can easily tear those vessels, leading to that complication we all dread, avascular necrosis. The bone literally dies. The Pauwels classification is a really neat way to predict how stable these fractures are, and it's all based on the angle of the fracture line. So a Pauwels type I, that's an angle under 30 degrees, it's more horizontal. When a patient puts weight on it, you get compressive forces, which is actually great for healing. But as that angle gets steeper, like in a type 3, it becomes more vertical. Now, weight bearing creates these massive, unstable shearing forces that are actively working against the fracture healing. Right, let's get into management. For femoral neck fractures, the decision tree gets pretty complex, and it really all pivots on one single critical factor. So I'll pose the question to you. Why do we completely change our treatment strategy based on how old the patient is? And we're not just talking about a number here. We're talking about physiological age, which reflects different demands, different bone quality, and most importantly, completely different goals for our treatment. And here's the payoff. In a younger patient, our number one goal is to save their own femoral head, no matter what. We'll accept the risks of non-union or even necrosis for the chance to preserve their native joint. So we do an osteosynthesis. We fix the bone. But for an older patient who's less physiologically resilient, the goal flips completely. We have to get them up and moving right away to avoid all the nasty complications of being stuck in bed. So for them, the definitive treatment is a hip endoprosthesis, a replacement, which gives them immediate stability and lets them bear weight early. Okay, let's shift gears now. We're moving from the intracapsular neck out to the extracapsular, trochanteric, and subtrochanteric regions. And out here, the biology, the blood supply, the surgical approach, it's a whole different ballgame. The most important thing to know here is the blood supply. Unlike the femoral neck, the trochanteric region is made of spongy, cancellous bone with a rich, robust network of blood vessels. What this means is that these fractures have a fantastic biological environment for healing, which makes our job and our treatment goals a lot more straightforward. So, what's our go-to implant for these? It's the proximal femoral nail, or PFN. This thing is the absolute workhorse for trochanteric fractures. It's an intramedullary device, meaning it goes right down the inside of the bone, and it creates a really strong, stable, load-sharing construct. Let's break down exactly how it works, because it's actually biomechanically pretty brilliant. First, the nail goes down the shaft of the femur.
Second, a big lag screw gets inserted through the nail and up into the femoral head, grabbing onto the main pieces. But here's the magic trick. That screw is dynamic. It's designed to slide within the nail. This allows the fracture to settle and compress under the patient's own weight. And that dynamic compression, it's a powerful stimulus for bone to heal.
Now, what if the fracture goes a bit further down the shaft, into that subtrochanteric zone? It's a quick modification. The principle is exactly the same, but we just use a long PFN. This simply extends the stability further down the femur, effectively bridging that whole fracture zone to make sure we don't get any nasty angular deformities.
We have covered a lot of ground, so let's boil it all down to the most critical, high-yield takeaways. These are the points you need to lock in for your exams and for your rotations.
First, intracapsular neck fractures mean a high risk of avascular necrosis. Got it. Second, the patient's age is the key factor for neck fractures. It's always a balance between preserving the head versus getting them moving early. Third, trochanteric fractures have a great blood supply and amazing healing potential. Fourth, the PFN is the undisputed king, the standard of care for these trochanteric injuries. And finally, don't forget the Pauwels Classification to assess the biomechanical stability of femoral neck fractures.
You know, in the end, it really all comes back to this one idea. If you can truly grasp the relationship between the fracture's location, how that affects its blood supply, and the mechanical forces at play, well, then you can reason your way through the diagnosis and management of pretty much any proximal femoral fracture that comes your way. And that, right there, is the foundation for providing excellent patient care.